Hello, and welcome to the Health Equity Training. My name is Jorden Laducer-Dix. I am the Special Populations Coordinator through the Community Engagement Unit here at the North Dakota Department of Health and Human Services. I will serve as your trainer for this presentation. By taking this training, you are embarking upon an important first step to providing equitable access to health care for populations you directly or indirectly serve. We are glad that you are here. You have tuned into the Social Drivers of Health, previously known as the Social Determinants of Health module. Throughout the training, you'll hear me referring to social drivers of health as social drivers. We have 7 course objectives today. By the end of the training, you should be able to identify the Community Engagement Unit, understand what is health equity and why does it matter, define social drivers of health and the types of ecosystems, understand the relationship between social drivers of health, health disparities, and health inequities, define health-related social needs, and understand the difference between health-related social needs and social drivers of health, describe population-specific social drivers of health, and finally, understand and apply the existing framework and models to address the social drivers of health. The mission of the Community Engagement Unit is to understand and reduce health disparities among all North Dakotans. The primary goal is to work alongside North Dakota communities in addressing health-related needs to reduce disease rates by providing opportunities for interventions and improving access to health care. This will ensure that all North Dakotans have the ability to reach their optimal health. To achieve our goal, we need boots on the ground, which is where our community engagement team comes in. The community engagement unit started with 1 individual in 2018 and now consists of 13 staff, including population specialists on topics such as rural, aging, persons with disabilities, youth, tribal, NFI, which is the largest growing demographic in North Dakota, and NFI stands for New Foreign-Born Immigrants, the LGBTQ2S+, and etc. We have our specialists, but recognize the intersectionality between populations. An example of this would be young tribal members. They would be youth plus tribal communities. The aging population in rural North Dakota, which would consist of the aging population plus rural North Dakota. Persons with disabilities, who is a part of the LGBTQ2S+ community. This would refer to a person with disabilities and the LGBTQ2S+ community. Populations we serve and lift up, overlap, and intersect, which makes us as a part of a team. With many different scopes of work closely together. Here, we listen to communities to identify gaps in healthcare, coordinate services, bring community needs back to the North Dakota Department of Health and Human Services, to address and to provide important information to communities hit hardest by disparities. This would include COVID-19 especially. So why does health equity matter? Health equity matters because health equity is giving everyone the same opportunity to the highest level of healthcare that meets their needs. We know that health influences all areas of life. Health equity strives to improve the quality of life. Achieving health equity improves all areas of our physical, mental, and emotional well-being. Here is an example of the difference between health equity and health equality. Equality, as you can see on the left-hand picture, everyone gets the same, regardless if it's needed or right for them. Whereas equity is on the right side of the picture, and it stands for everyone gets what they need in understanding the barriers, the circumstances, and the conditions. Now that we have a better understanding of what health equity is versus health equality, we need to dive into our main subject, social drivers of health. So, why are we changing the language from social determinants of health to social drivers of health? After all, the data behind social determinants of health shows that by focusing on them, health outcomes improve. Well, that is true, but as far as language goes, the word determinants can suggest that nothing can be done to change the fate of our health. It's already been determined for us by our environment. Without intending to, we can take away people's sense of choice or even control. By using the term social drivers or social drivers of health instead of social determinants, we show that social factors don't force health to be fated or destined, but rather they are something that people and communities can overcome or even change. Social factors drive our health. They don't have to determine them. Determinants are things that can't be controlled, but drivers can be changed and pushed towards better health. There's a big difference there. Just by choosing a different word, it changes the narrative in a positive, proactive, and helpful way. Did you know that many people recognize that their health is impacted by their decisions? Eating well, exercising, avoiding smoking, getting recommended immunizations, and more? However, the impact of where we live, work, access healthy food, and have social relationships play a significant role in our health, which is known as social drivers of health. Social drivers of health describe the conditions in the environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health functioning and quality of life outcomes and risks. They are those components that influence a person's health outcome beyond just going to a clinic, like our physical environment, accessibility, and healthy behaviors. In fact, clinical care impacts only 20% of health outcomes, while social drivers affect 50% of health outcomes. Social drivers play a crucial role in shaping individuals' lives and influencing their well-being and longevity by constituting the foundational social and structural elements essential for livelihood. These drivers can have positive effects contributing to the promotion of better health. On the other hand, when they take a negative turn, they have the potential to undermine health. Social drivers are not similar or equitable across all populations. Many of the ongoing health inequities are present due to historical injustices. Therefore, in order to move forward, sometimes we must look back. Many people of color, for an example, continue to experience the long-term consequences of unjust policies and practices due to redlining and limited homeownership. Redlining is a practice of banks and/or lenders not giving loans or housing services to our communities of color. These illegal practices lead to modern-day inequities in health outcomes like underfunded neighborhoods, leading to families living in communities where toxins like lead and the lack of grocery stores are common. For an example, when people don't have nearby grocery stores with healthy food choices, they're more likely to have poor nutrition. This limitation increases the likelihood of poor nutrition, subsequently raising the risk of health conditions like heart disease, diabetes, and obesity. On the flip side, when people have access to grocery stores providing healthy food options, it acts as a protective factor, reducing the risk of experiencing adverse health outcomes. It is crucial to acknowledge that social drivers become potential factors contributing to poorer health outcomes when obstacles arise and one or more of these factors are determined. Therefore, understanding and addressing the positive and negative aspects of social drivers are essential for promoting overall health and well-being. When talking about social drivers of health, the Healthy People Initiative has identified 5 areas that they will focus on: education, access and quality, healthcare access and quality, neighborhoods and built environments, social and community contacts, and economic stability. Let's begin with education, access, and quality. This domain of the social drivers include early childhood education, literacy, language, vocational training, and higher education. Early and continued quality education of a child has been associated with positive long-term impacts on the child's social, cognitive, emotional, and physical development, such as being healthier or even living longer. However, it is worth noting that the social economical status of a young child's family and community affects their educational outcomes significantly. Children from lower income homes, children with disabilities, and those who have faced social discrimination are more likely to have difficulties in school. This includes graduation rates, meaning they are less likely to graduate from high school or attend college. In return, they are less likely to get safe, high-paying jobs and are more likely to have health problems like heart disease, diabetes, and even depression. As we explore health and healthcare access and quality, it is important to talk about access to health services, primary care, and health literacy. In the upcoming slides, we'll explore further into the second domain of social drivers, explaining what each of these means and how they are related to the social drivers of health. Healthcare access is being able to acquire personal health services timely to achieve the best possible health outcomes. However, many people need help with challenges preventing or limiting their access to healthcare services, a situation that has the potential to increase the risk of poorer health outcomes. These barriers include uninsured health insurance, underinsured, or even inconvenient or unreliable transportation. Additionally, longer wait times, delayed care due to a shortage of physicians are other barriers to accessing timely health care. Primary care is a provision of integrated, accessible healthcare services by clinicians accountable for addressing a large majority of personal healthcare needs, developing a sustainable partnership with patients and practicing in the context of family and community. Studies show that timely access to primary care results in positive health outcomes such as early detection and treatment of disease, chronic disease management, and preventative care. However, disparities in the context can result in decreased access to services and increase the risk of poorer health outcomes. We've talked about some examples to why it is hard to get access to healthcare services previously, like not having insurance or transportations, but there are other things that can make it tough to get primary care too. For instance, additional obstacles could include, but not limited to, disabilities, not being able to take time off of work for appointments, and not speaking the same language as your doctor are some of the many reasons why people might find it hard in accessing healthcare services. Cultural barriers to accessing healthcare services can significantly impact individuals' ability to receive timely and appropriate medical care. These barriers may stem from differences in language, beliefs, values, customs, and traditions between healthcare providers and their patients. For example, individuals from certain cultural backgrounds may have specific beliefs about health and illness, leading them to seek alternative treatments or delay seeking medical care. Addressing these challenges requires recognizing and actively working to eliminate discriminatory practices. Building trust among those who have experienced unfair treatment or racism is essential for fostering equitable access to primary care. Implementing policies that prioritize inclusivity or cultural competency is vital in ensuring equitable access to essential healthcare services for everyone. It is important to acknowledge that these barriers may interact, resulting in reducing access to primary care. Evidence-based interventions to tackle healthcare access and quality challenges include expanding access through affordable health insurance coverage, utilizing digital solutions such as telehealth to overcome transportation barriers, and offering services in language other than English. Now, Let's talk about health literacy. Health literacy has been declared as a foundational principle and overreaching goal by Healthy People 2030. With that, two sets of definitions have been adopted for the phrase personal and organizational health literacy. Personal health literacy is the degree to which individuals can find, understand, and use information and services to inform health-related decisions and actions for themselves and/or others. This is associated with factors such as racial, ethnic, minority status, age, poverty, educational attainment, and language spoken before school. In fact, personal health literacy has been suggested as a social risk. It has been related to negative health care and health outcomes because when people have limited personal health literacy, there is a tendency to misunderstand information that is important to achieving and/or maintaining health, or to a larger extent, resulting in their inability to navigate the healthcare system. Let's consider a simple example of a personal health literacy. Tom is a person in their 60s receiving a prescription from their doctor for a new medication. Having a higher personal health literacy, Tom reads the medication label carefully, understands the dosage and the instructions, and asks his pharmacist questions to ensure they take the medication correctly. This is an example that showcases how personal health literacy enables individuals to navigate healthcare information, understand prescriptions, and actively manages their health. Now, let's take a look at a bad example of Tom. Let's consider a scenario where low personal health literacy has a negative impact. Tom, a person in their 60s, receives a prescription from their doctor for a new medication. However, due to his low personal health literacy, Tom struggles to understand the dosage and the instructions and the potential side effects of the medication. He may feel overwhelmed and unsure about how to take the medications properly, leading to the potential of mistakes or missed dose. Tom's lack of health literacy could result in him not receiving the full benefits of the medication or experiencing adverse effects due to the incorrect dosage. This example showcases how personal health literacy does not enable individuals to navigate healthcare information, understand prescriptions, and does not actively manage their own health. Organizational health literacy is the degree to which organizations equitably enable individuals to find, understand, and use information and services to inform health-related decisions and actions for themselves and others. When an organization needs more health literacy, it can reduce the healthcare delivery quality. Consequently, individuals living in such communities would have negative health outcomes, as such individuals may suffer from miscommunication and difficulty accessing services. It is important to improve organizational health literacy as it has the potential to reduce observed health disparities. One way to be health literate organization is to meet the population's need by ensuring that everyone, regardless of their abilities, can use health information and services. Imagine a medical clinic implementing organizational health literacy practices. They redesign patient forms, simplify language, and provide clear instructions. To further explain this, let's use Mark as an example. Mark, a patient with limited health literacy, arrives for an appointment, and the receptionist uses plain language to guide him through the paperwork. The clinic's efforts to enhance organizational health literacy ensures that Mark can easily navigate the administrative aspects of his healthcare, promoting a more patient-friendly experience. This is a clear example of organizational health literacy. Consider the negative impact if a medical clinic fails to implement organization health literacy practices. Without redesigning patient forms, simplified language, and clear instructions, individuals like Mark, who have limited health literacy, may struggle to complete paperwork accurately. In this scenario, the receptionist's failure to use plain language amplifies Mark's difficulties, leading to confusion and frustration during the appointment. The absence of efforts to enhance organizational health literacy results in barriers to accessing healthcare for individuals with limited health literacy, hindering their ability to navigate administrative tasks and ultimately compromising their overall healthcare experience. This highlights the importance of organizational health literacy in promoting patient-friendly practices and ensuring equitable access to healthcare services. Now that we have a better understanding of health literacy, personal health literacy, and organizational health literacy, let's begin to discuss neighborhood and built environments. The third domain, being neighborhood and built environment, the social drivers related to this domain includes factors such as access to stores selling healthy foods, crime and violence, environmental conditions, and housing quality. The social drivers, neighborhood and built environment, also have critical issues with access to transportation. A barrier people may face is access to ready and reliable transportation, which they may need help to evacuate in response to an emergency. Therefore, they may be negatively impacted during an emergency, which establishes an inequity that people may face within their neighborhood and built environment. In the following slides, we will dig deeper into how the third domain of social drivers, neighborhood and built environment, relates to healthy foods, crime and violence, environmental conditions, and housing quality. Access to healthy food is crucial when talking about social drivers that significantly influence our overall well-being. It encompasses the availability, the affordability, and proximity of nutritious food options that support healthier dietary patterns. Individuals with convenient access to fresh fruits, vegetables, whole grains, lean proteins, and other essential components of a balanced diet are better positioned to maintain a better health outcome. This aspect of the social drivers recognizes the environmental and social economical factors often impact one's ability to make healthier food choices. Challenges such as living in food deserts, where nutritious options are scarce, limited financial resources, and transportation barriers can hinder individuals and communities from accessing and or incorporating healthier foods into their diets. Research shows that healthy dietary pattern is associated with reduced risk of disease, obesity, type 2 diabetes, and even bone health. Having access to healthy and affordable food is prominent for an individual to achieve a healthy dietary plan. While this is proven, certain individuals and or populations are unable to access and or make healthy food choices due to distance of the grocery stores, lack of transportation, and higher prices of healthy food. Addressing disparities in access to healthy food will improve in implementing policies and interventions that promote food equity, eliminating food deserts, and make nutritious options more affordable and accessible. By recognizing and addressing these social drivers, communities can work towards to ensuring that everyone can make a healthy food choice, ultimately improving overall health outcomes. Let's dive further into access to healthy food and discuss an example of this. Joe, who has chronic heart disease and has diabetes, is unable to afford a car and the bus line doesn't go by their home. He is only able to walk a few blocks given his health challenges. This makes it very hard to go to the grocery store nearly a mile from his home. Instead, he walks to a local gas station convenience store that sells processed foods such as pizza and candy, and so much of his diet comes from these sources. Joe's situation provides an example of how limited access to healthy foods can increase health challenges, especially for individuals with chronic conditions like heart disease and diabetes. Joe faces significant mobility challenges when he lives without access to a car and with limited public transportation options that does not reach his home. In this example, Joe's limited access to healthy food is not only merely a matter of inconvenience, it becomes significantly a barrier to make nutritious choices that could positively impact his food and scarce to his health. Addressing the situation would involve interventions to improve Joe's access to healthier food options, potentially through local initiatives like community gardens, partnerships with local markets, or transportation solutions tailored to individuals with health challenges. By addressing the social drivers of limited access of healthy food, the community can contribute to improve Joe's overall health outcomes and quality of life. Crime and violence is also related to the social drivers in neighborhood and built environment. Every individual and/or population can potentially be affected either directly or indirectly by crime and violence. Some of these include child abuse and neglect, firearm violence, domestic violence, sexual violence, and even elder abuse. However, certain groups and/or populations are at higher risk of experiencing crime and violence, such as low-income neighborhoods. To be more precise, violence itself is a social driver, yet violence can also be caused by the environment in which people live and grow. Those who grow up and live in situations with limited social, educational, and economic prospects, as well as where there is violence, racism, community, and domestic instability, are daily stressors, are more likely to engage in multiple forms of violence. Therefore, in order to assist in the prevention of violence, it is imperative to address the root cause, which stems from underlying social drivers, including inequities and social disadvantages experienced by various populations. The environment in which we live has a significant impact on our lives. Although the current quality and state of environmental conditions are essential aspects of our daily lives and occurs naturally, they are frequently influenced by historical, economic, and social political factors. The situation results in certain populations being more prone to poorer environmental conditions. For example, environmental conditions such as water quality, air quality, and weather are often vary among populations and geographic locations. Discussing the quality of housing, it is helpful to consider it in terms of affordability, stability, quality, and safety in surrounding neighborhoods, as each of these has the potential to influence health outcomes. Housing quality is a physical condition of the individual's home as well as the quality of the social and physical environment in which the home is located. It is fundamentally influenced by the home design, structure, as well as location. Often, in health discussions, the term upstream issues is employed as a metaphor to illustrate the interaction of various factors leading to observed health disparities and inequities. This metaphorical stream is divided into three segments: upstream, midstream, and downstream, illustrating their interconnectedness where upstream factors lead to downstream effects. Upstream factors are the root cause stemming from social and economical conditions resulting in the social drivers differences and downstream effects. Therefore, interventions to resolve these root causes of observed social, economical, health inequities such as education, employment, and poverty are applicable to the community level. At the midstream are the human services such as community-based organizations, social services providers, which may refer to connect individuals to assist for social needs. These sectors function to reduce and/or mitigate the effects of the social drivers that are related to the health and the individual level. Some of these services include the provision of transportation needs. The downstream encompasses the effect of social drivers on the community. The observed health disparities and inequities from the downstream effects of the social drivers. In the development of comprehensive strategies and policies aimed to addressing the root cause of the observed disparities, it is important for cross-collaboration and strengthened partnerships across all these segments. Now that we have a better understanding of neighborhood and built environments and other domains associated with this, let's explore the fourth social driver, social and community context. Social and community context is related to the neighborhoods and built environments, focusing on how people feel being a part of the community and how active they are in that community can affect their health outcomes. The social and community context incorporates various factors that influences health outcomes and well-being within the broader social and cultural context. This includes key elements such as civic participation, discrimination, incarceration, and even social cohesion. Let's move on to our fifth and final domain, economic stability. The federal poverty level serves as a standard measure to assess whether individuals or families can meet their basic needs. Economic stability includes factors such as income, employment, and financial resources, which significantly influences health outcomes and overall well-being. The influence of economic stability can be seen in various areas, including access to healthcare, healthy foods, safe housing, and overall mental well-being. The key components of economic stability within the social drivers, according to the U.S. Department of Health and Human Services, include number one, income. Higher income levels correlate with better healthy outcomes, while lower income levels may contribute to health disparities. Number two, employment. Stable and secure employment provides financial resources and contributes to a sense of purpose, social connection, and overall mental well-being. And number three, financial resources. Beyond income and employment, financial resources such as savings, assets, and access to credit enable individuals to navigate unexpected expenses, access education, and invest in health promoting activities. Now that we have gained a better understanding of social drivers and how they frequently, though not always, contribute to inequities, it is important to examine the role of health-related social needs in relation to social drivers and their distinctions. When considering social drivers, we must first grasp the concept of health-related social needs. Health-related social needs and social drivers of health are occasionally used interchangeably. Health-related social needs refers to the social and economical needs that individuals experience that affect their ability to maintain their health and well-being. Health-related social needs includes housing and stability, housing quality, food insecurity, employment, personnel safety, lack of transportation, and affordable utilities, and even more. While everyone has social drivers of health factors, some populations and individuals may have health-related social needs because of these factors. However, it is important to distinguish can be made between health-related social needs and social drivers of health. As we know, social drivers refers to the conditions in which people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. The social drivers are broader social conditions, whereas health-related social needs are more immediate to the individual and or family needs impacted by those conditions. Health-related social needs encompasses essentials such as housing, food, and their limited access has a profound effect on individuals' health. In essence, disparities in health-related social needs can be contributed to the influence of social drivers of health. Now that we have a clearer understanding of health-related social needs and how they differ from social drivers, let's dig deeper into how various populations are impacted by social drivers. Health disparities are apparent among different racial, ethnic, and underserved groups. It is crucial to recognize that population diversity is increasing in North Dakota and across the United States. In fact, researchers estimate that by 2050, at least 50% of the U.S. population will be people of color. It is important that we strive for positive health outcomes across all population groups to prevent a widening disparities in healthcare access. According to Healthy People 2030, health equity is defined as the achievement of the highest level of health for all people. Health equity acknowledges that not everyone has equal opportunities to achieve optimal health outcomes. Access to healthcare is affected by institutional and structural barriers stemming from longstanding inequities. These inequities mean that social drivers such as education, housing, environment, and employment opportunities impact an individual's ability to secure a decent livelihood, work in a safe and healthy environment, and effectively access healthcare resources. In the next few slides, we will explore and discuss how social drivers to different population-specific health outcomes and barriers these communities face. The populations we will focus on are rural populations, American Indian and Alaska Native populations, other minority populations, and limited English proficiency populations. The Rural Health Information Hub explains that despite the advantages of living and working in rural areas, these communities experience significant health disparities. Factors like income level, education, race, ethnicity, and health literacy affect people's ability to access health care and meet basic needs such as clean water and safe housing, crucial for maintaining health. Poverty stands out as a major social factor influencing health outcomes in rural areas. Additionally, other disparities include higher rates of disease and disabilities, increased mortality rates, shorter life expectancies, and higher rates of chronic pain. The Rural Health Information Hub also states that geographic isolation, lower socioeconomical status, higher rates of health risk behaviors, limited access to healthcare specialists and subspecialists, and limited work to prospects are risk factors that pertain to rural health disparities. Individuals who live in rural communities are less likely to have employer-provided health insurance coverage and may not be Medicaid eligible. American Indian and Alaska Native communities are diverse in terms of history, culture, disease, and nutritional health. In North Dakota, there are 5 federal recognized tribes and 1 American Indian Alaska Native community partially within the state: the Mandan, Hidatsa, and Arikara Nation, 3 affiliated tribes, the Standing Rock Sioux, the Spirit Lake Nation, the Turtle Mountain Band of Chippewa Indians, and the Sisseton Wahpeton Oyote Nation. National statistics highlight significant challenges faced by American Indian Alaska Native communities, ranking them below average for healthcare access and the highest for negative health statistics among ethnic and racial groups. Social drivers specific American Indians shed light on disparities and challenges within these communities. Factors such as cultural diversity, access to healthcare, high rates of chronic conditions, social economical disparities, life expectancy, diabetes, rural and frontier challenges, and the importance of cultural competency in healthcare delivery play crucial roles in shaping the health outcomes and well-being of the American Indian Alaska Native population. Addressing these population-specific social drivers for American Indian Alaska Native requires a comprehensive and culturally sensitive approach. Initiatives aimed at improving healthcare access, economic opportunities, educational resources, and community engagement are vital for promoting health equity within American Indian Alaska Native communities. To have a better understanding of population-specific social drivers, let's focus on minority populations on this slide. Racial and ethnic minorities' social drivers is significantly impacted by both structural and individual discrimination, according to the Healthy People of 2030. North Dakota's racial and ethnic diversity has grown largely in the last decade. Minority populations contribute to unique challenges and health disparities. Various factors play a role in shaping the health outcomes in minority communities. One could be social economical disparities. Minority populations are often faced with social economical challenges, including lower income levels, limited access to educational opportunities, and employment disparities. These economic factors can be impacting overall well-being and access to essential resources. Another could be discrimination and racism. Discrimination and racism are significant determinants affected by health and minority population. Systematic discrimination in various sectors include healthcare, education, and employment contributes to disparities within health outcomes. Another could be cultural competency in healthcare. Cultural competency in healthcare deliver a crucial for addressing the unique needs and beliefs of minority populations. Lack of cultural understanding can lead to mistrust, underutilization of healthcare services, and disparities within the healthcare quality. Access to healthcare services is another. It states that within a minority population may face barriers in accessing healthcare services, including geographic disparities, lack of healthcare insurance coverage, and limited availability of cultural competent healthcare providers. These factors contribute to disparities in healthcare access and utilization. Language and barriers can hinder the effective communication between healthcare providers and minority individuals. Limited availability of language interpretation services may result in misunderstanding and suboptimal healthcare delivery. Immunization status is another factor. Minority populations, especially immigrant communities, may face challenges related to immigration status, fear of deportation, and limited access to healthcare services for undocumented individuals contribute to healthcare disparities. Health literacy. Disparities in health literacy levels among minority populations can impact their ability to navigate the healthcare system, understand medical information, and make informed healthcare decisions. Historical trauma stemming from the past injustices and systematic oppression can have enduring effects on the health and well-being of minority population. Recognizing and addressing historical trauma is essential for comprehensive healthcare strategies. And finally, social support networks. Minority communities may experience variations in social support networks. Strong social support can positively impact mental health and resilience, while social isolation can contribute to negative health outcomes. As previously discussed with American Indian and Alaska Native communities, addressing population-specific social drivers for minority populations requires targeting interventions, policies, promoting equity, and initiatives aimed to eliminate systematic barriers. Culturally sensitive healthcare education and employment practices play crucial roles in promoting health equity and improving overall health. After discussing population-specific drivers of rural health communities, American Indian Alaska Native communities, and minority populations, we must now discuss populations with limited English proficiency and challenges they face. Limited English proficiency communities face unique challenges that impact health outcomes. These include, but are not limited to, language barriers, access to healthcare services, cultural competency, availability of interpreters, health literacy, and employment opportunities. Providing appropriate health education materials, expanding interpreter services, and promoting inclusive healthcare policies will contribute to improving health equity for communities within the limited English proficiency. Now that we have a basic understanding of different populations and the barriers face regarding the social drivers, we must now discuss existing frameworks for addressing social drivers. Several social driver frameworks have been established to assist communities, healthcare professionals, and others in better understanding and addressing a wide range of health-related problems. Although there are different types of existing frameworks that address the social drivers, we will be focusing on three different frameworks that include Healthy People 2030 framework, the CDC framework, the World Health Organization, WHO framework. As mentioned earlier, the mission of Healthy People 2030 is to promote, strengthen, and evaluate the nation's efforts aimed to enhancing the health and well-being of every individual. It also seeks to foster social, physical, and economic environments that promote attaining the full potential for health and well-being for all. Many of the goals related to the social drivers framework and Healthy People 2030 align closely with the overarching aim. The goals draw attention to the significance of the upstream factors, which typically unrelated to healthcare delivery, is improving health outcomes and reducing health inequities. The Healthy People 2030 framework focuses on 5 pillars as discussed in the module's beginning. These pillars include economic stability, education, access and quality, healthcare access and quality, neighborhood and built environment, social and community context. However, as stated in Healthy People 2030, simply encouraging healthy lifestyle choices would not erase these or other health inequities. Instead, public health organizations and other partners in other sectors, such as education, transportation, and housing must take action and improve conditions in people's environments. With that being said, what other types of frameworks could be utilized to highlight how disparities in social drivers can be addressed throughout leveraging data and generate evidence supporting health equity research? Let's dive further to see what other frameworks are being used to address social drivers. To address social drivers, the CDC has proposed 6 framework pillars. In the fall of 2021, the CDC leadership began an agency-wide process to build and expand cross-cutting efforts to address social drivers by taking multiple steps to ensure that efforts to address social drivers are built into the agency's work rather than being confined into a single program. The work directed by the National Center of the Chronic Disease Prevention and Health Promotion resulted in 6 pillars. The first pillar is data and surveillance. This framework incorporates a consistent social driver strategy for data standardization, collection, analysis, and dissemination throughout agency networks. The second pillar is evaluation and evidence building. This framework focuses on advancing evaluation and evidence building for social drivers related to strategies to minimize inequities and promote health equity. The third pillar is partnerships and collaboration. As simplistic as this framework sounds, it is about establishing criteria, actionable steps, and strategies for long-term health outcomes in partnerships, collaborations, and relationships. The fourth pillar is community engagement. Encourage meaningful long-term community engagement throughout all intervention designs and implementation plan strategies. Being connected to the community and having personal perspectives that can drive initiatives. The fifth pillar is infrastructure and capacity. To address social drivers and reduce health disparities, this framework focuses on infrastructure such as workforce, training, and access to financial resources must be strengthened and sustained. This could include containing education and looking inward internally to better address health disparities and how you are serving your community and your workforce. The final and sixth pillar of the framework the CDC recommends is policy and law. Like the fifth framework, policy and law focuses on looking inward internally to better address health disparities and the communities they serve. This framework requires organizations to identify evidence, strategies, and resources to improve communication with policymakers and other stakeholders regarding policies affecting social drivers. The World Health Organization, also known as WHO, focuses on social drivers action-oriented framework that demonstrates how social, economical, and political context structural determinants of health inequities and intermediate drivers of health influences the role in determining health outcomes. These factors can have the impact on a person's ability to live a healthy life by influencing things like housing quality, built environment, chances for physical activity, and access to healthcare services. WHO believes that addressing the social drivers appropriately is fundamental for improving health and reducing long-standing inequities in health. With WHO's framework, the social drivers are categorized into 2 basic kinds that interact and influence health and well-being. These drivers are classified as structural drivers, which include social economic status and community context, and intermediately drivers, which include people living in working conditions. To address this, WHO has identified 3 framework pillars in order to better address social drivers: improving daily living conditions, the circumstances in which people are born, grow, live, work, and age, tackle the inequitable distribution of power and money resources, the structural drivers of those conditions of daily life. And 3, and finally, measure and understand the problem and assess the impact of action. Expand the knowledge and base, develop a workforce trained in social drivers, and raise political awareness about social drivers. Congratulations! You've reached the end of this module. By now, you should be able to define the social drivers of health, the types of ecosystems and social drivers of health, understand the relationships between social drivers of health and health disparities and health inequities, Define health-related social needs and understand the difference between health-related social needs and social drivers of health. Describe population-specific social drivers of health. And finally, understand and apply existing framework and models to address social drivers of health. And as a reminder, social drivers are often, but not always, the reasons why inequities exist. Many social drivers have been shaped by upstream issues. Systems that don't focus on social drivers will tend to intensify inequities. Thank you for joining me today. I hope you enjoyed the social drivers of health module, and we are excited for you to incorporate what you learned today into your daily interactions. Don't forget to tune into our other training modules on PeopleSoft, the Health Equity website, and the North Dakota Train.